As they say, you saved your best for the last. So here we are. And he's best because he's got the money. Pay attention. Our next speaker is Dr. Richard Kwok. Correct? I asked him how to pronounce it. He's the program director for the Population Studies and Genetics branch of the Division of Neuroscience at the National Institute of Aging. He's been an environmental epidemiologist with experience in multi-site epidemiological studies. He will be talking to us today about bridging the gaps, exploring novel frontiers in health, disparity in research, aging, Alzheimer's disease, and related dementia. Dr. Kwok.
Thank you so much. Can folks hear me? Is that okay? I don't have the money, but I work with people who have the money. And so actually I'm pretty new at NIA. I just joined in 2022. And I mentioned that I'm an environmental epidemiologist, so kind of approaching it from that lens. And so when they came to ask, when you asked me to come and give a talk about disparities, I'm kind of looking at it more from like an environmental justice type lens. But obviously, I'll talk about that and then how we really do need an interdisciplinary approach to addressing these issues. So so what role does the exposome or the environmental health play in brain health and AD disparities, and by what mechanisms? So just looking at the data, and I've been listening online for the past day and a half, and then I came in late this morning. That's the environmental section. You can kind of see there really are marked differences in the rate of dementia between the different racial and ethnic groups. In this example from 2016, in an integrated healthcare delivery system. But this is kind of the framework of how I'm approaching the environment and AD/ADRD. It involves a lot of disparate and complex data sets, and I think this is really a good figure to think about air pollution, and especially ultrafine particles and traffic-related air pollutants as risk factors for AD/ADRD. This figure illustrates how the exposures and risk factors on this left contribute via this initial exposure through an initial molecular and cellular effects in the target tissue, through pathophysiological responses to earlier but detectable subclinical effects, and then ultimately to the disease state of interest. Now, ideally, a research program would be able to consistently document effects all the way along this route. Realistically being able to demonstrate the entire cascade from exposure to disease. And this would really require different kinds of study designs, be it observational, experimental, both hypothesis generating and hypothesis testing, both in humans and animal and cellular models. But this figure is also really good in terms of illustrating the interaction between the genetic and biological risk factors, including sex and age, and risk of disease processes. Importantly, this illustration also shows the two main places where the interplay between environmental factors and social factors can result in different health disparities. So both first in exposures, there are key differences between different social groups and exposures, for instance, environmental racism and other phenomena. But then also the second feature here in the social environment in terms of neighborhood social economic status, built environment, educational opportunities, exercise habits, can influence the occurrence of the exposure-related disease and these different resilience factors. So, a number of studies have documented exposures start early in childhood can impact diseases later in life. And so, especially with diseases of unknown origin with long latency periods like AD, perhaps it may be an opportunity to look at other cohorts that are well characterized environmentally and that have collected data earlier in stages of life. And so this is just an example from Calderon Garces, who had done a nice study in Mexico City on air pollution and AD in children. Moving on. So this is just a very complicated diagram, but kind of shows kind of all of the different pathways that can lead from an exposure, in this example, either inhalation or ingestion, to an Alzheimer's pathology, and all the different pathways that could be explored that have been traditionally underexplored. Within this field. I mean, when I first started, a lot of the incidence of Alzheimer's disease related to genomic factors like ApoE4, really only explain a fraction of the incidence of the disease. So, perhaps there's a lot of, there's a lot of opportunity here to study a lot of these different processes and how it may impact AD-ADRD pathology. So the exposome in practice, you have like kind of like the general, external, down to specific external measures, and then the internal. And this is from IROS in the University of Utrecht that published this paper, but I really liked it because it kind of thinks about the universe of environmental factors and to think more broadly about these non-genetic factors and how it influences disease. So for AD-ADRD, it's likely even more true that some of these factors can play a role not only in promoting the pathophysiological processes, but also in either increasing or decreasing the resilience to disease expression among those with AD-ADRD pathology. So I like to think about which factors are modifiable. And so at some level, some are modifiable at an individual level, but some require, that are modifiable at the community level, either at the built environment or local ordinances, and some are really only modifiable at societal or national level. So looking at like air pollution regulation or climate change, so public policy regulations may have an impact on that. And some may argue that others may be non-modifiable at all. So for instance, your genetic structure. Now that this doesn't pretend to proteogenomics, epigenomics, and others as well. But much of the work is spent understanding sources of variation and correlation structures with these other risk factors. So kind of having a better handle in terms of how these are manifested and how built environment and these different disparities are manifested in the pathophysiology, is of strong interest to us. But also in investigating biomarkers of exposure. So is there a biomarker exposure? Can we measure it? Is there a blood-based biomarker? So I know we had a whole session about this at this workshop, to talk about, can we measure measures of effect earlier on? And then also taking advantage of new measurement technologies. So both in terms of measuring exposures, but then also outcomes along the etiological pathway. So some of NIA's research priorities related to the environmental health sciences more broadly is looking at exposures throughout the life course and how this shapes health outcomes of the older adults. So looking both at early and mid-life stages. And then also how the timing, duration, and intensity of these different exposures, be it physical, chemicals, sociological, geographic or economic, over the life course impact later life and well-being. And then NIA recognizes that more research is needed to best capture how this comprehensive set of exposures known as the exposome affects risk and resilience associated with AD-ADRD. So not only these physical chemical effects, but then how it manifests itself into the body, and then getting into both targeted and untargeted metabolomics to try to identify potential markers. So so the program premise is really this is from the AD Summit back in 2018. Actually, we've been holding these summits annually, and there's actually one later in September, I think. And so it really is centering the diversity, understand the heterogeneity that exists within these different racial, ethnic populations. And as you guys are very familiar with, much of the data is based on non-Hispanic white populations. So NIA is very interested in diversifying that population not only here in the US, but also in low and middle income countries around the world to diversify the population to look at these markers. But the successful implementation really requires collaboration across multiple disciplines, not just sociology, but also epidemiology, biostatistics, economics, and really moving from a precision medicine approach where you're kind of really identifying approaches that will be effective for patients based on a specific genetic and environmental and lifestyle factor to precision public health, where we're really trying to provide the right intervention at the right time to the right population, to the right populations at the right time. And so I like this figure here on the bottom right, which is this kind of a blow up of it from the health disparities framework, where we look at a variety of environmental, sociocultural, behavioral, and biological factors, and then across this life course perspective, and how this as a whole influences a population. So oftentimes it's hard to get a handle in terms of this large amount of data. But NIA is really devoted to try to promote this collaborative research, both to support the development of the infrastructure, so new tools, surveys, biospecimens, and data, and access to the data for a precision medicine approach, but really trying to create a catalytic opportunity for investigators to really focus on these populations that are understudied in ADRD research. So not only just non-Hispanic whites, but Asian, Latino, African American populations, Native American populations, and indigenous populations here in the U.S., but then also, as I mentioned, in the low and middle income countries in Africa and Asia and beyond, and South America and beyond. Really try to build resources that include neurobiological, environmental, behavioral, and social science data. So oftentimes some of these are often in a vacuum or very siloed. And so we're really trying to have common data elements and data harmonization efforts to kind of look across these different data silos and really try to initiate innovative, integrated, and expanded studies of individuals from these populations and to kind of look more broadly beyond the opportunities that are currently. So this is from the AD Research Summit back in 2021. Lisa Bryant mentioned that we really need to center diversity to understand the heterogeneity that exists among and within these racial and ethnic populations. So what we interpreted that as trying to be successful is that really a greater emphasis on joining biological mechanisms with social and environmental determinants of health to develop a precision approach to intervention in individuals. And really successful implementation requires multiple scientific disciplines. So really trying to be very collaborative across beyond just folks in your department. So the goal is, can we accurately determine risk-based on individual exposures and characteristics across the life course? Can these large multimodal biomedical data linked to social behavioral environmental exposures predict risk? And so Ross Wright had a nice paper in cancer, using cancer as an example, trying to answer this question. So can we make this vision a reality? Can we follow an individual over the life course and collect as much data as possible on these different environmental factors, and then so we can identify who's at risk earlier on, and then treat them, and not only follow them over that point in time, but really follow them through the course of treatment and beyond. And so using cancer as an example, hopefully we can find something with Alzheimer's disease and related dementias. But to do this well, it really takes a massive amount of data, but also thinking about it more from just the perspective of a single place. To do this well, it really takes many different perspectives that fall across many different diverse disciplines. I feel like I'm a broken record from saying being very interdisciplinary. But you can kind of see, this is from Roll Vermeulen, published in Science back in 2020. Looking at all of the lifestyle, ecosystems, social, physical, chemical factors that can contribute to health. I think Arnold had a really nice talk this morning about kind of linking across these different domains and how they may have an impact, especially on diseases with long latencies and so complicated like ADHD. But the data ecosystem really is poised for these novel tools and methods. Within this diverse data ecosystem, NIA has invested a lot in trying to leverage all these diverse data. So, we can include satellite data from NASA, NOAA, environmental exposure data like the EJ index from CDC and EPA, looking at GIS data from the Census Bureau and CDC, incorporating mobile digital health data from individuals using devices such as Apple watches and phones and Fitbits and other wearables, combining it with EHR data with Mori and other health systems, and then into large data repositories like the AD Knowledge Portal or NIGADS, and leveraging opportunities to work with the NIEHS HERE program, which is the Human Health Analysis, and then also the Common Fund Bridge to AI program. And then really trying to kind of put this all together while maintaining fair data principles, being findable, accessible, interoperable, and reusable. So this is just a talk in terms of looking at how NIA has made significant investments in creating and maintaining a very robust infrastructure for sharing diverse data types through the AD Knowledge Portal. There's a lot of over 60 different arrays and 50 different file formats in terms of specimens, data types, levels of process data. Those of you who have been fortunate enough to receive NIA grants or NIH grants since 2023 have now been encountering these new data management sharing plans. And so how best to share your data and the old ways of available upon request are no longer acceptable. So as a program officer, I've been talking to a lot of PIs, have been wrestling with this topic of how best to share their data, what repositories and where to put them, because having it at your institutional website, as you've done traditionally in the past, is no longer acceptable. But then moving on, I think a lot of this will make it much more publicly accessible to the research community to generate a more holistic effort. Let's see. So this is just a little bit about the AD Knowledge Portal infrastructure. There's different parts of it in terms of the data catalog and storage and contribution from all of these different models, and then ultimately lead to data discovery, processing, and results exploration. So a lot of it is kind of already built, so you don't have to build it yourself. But encourage you to kind of explore and use some of these resources that NIA has created in conjunction with the other NIHs. But the AD Knowledge Portal doesn't operate in a vacuum. There's a lot of other efforts there, and so so this is we're collaborating with ALSPEDS, NIGADS, NICRAD, the NAC. A lot of these consortia are depositing their data into these large multimodal repositories to make it accessible for researchers who are just starting out, or also well-funded investigators well along the lines to kind of bring their own data and ideas in terms of exploring and asking study questions based on it. So so this is really kind of like a systems network biology consortia looking at large scale team science. You're really generating high quality multi-omics data in addition to merging clinical genomic mechanistic research with social behavioral aspects as well, and looking at cross-species analyses and really rapid and broad sharing of data methods and results through a very centralized data infrastructure moving forward to hopefully manage all this. And so I think that I'm going to transition then to, now that we have all this data, what do you do with it? And so I want to talk about some of the advances in exposomics and artificial intelligence. And so having a lot of these high throughput technologies that have been generated with next gen sequencing, mass spec, and bioinformatics, it really allows for the simultaneous study and integration of multiple omics technology. And so very interested in both targeted and untargeted analyses of biological environmental samples. So for instance, using data from the NIH HERE program, but then also leveraging what sensors and personal dosimetry data, and with the advent of artificial intelligence and wider adoption of machine learning and large language models, it really is evolving extremely rapidly and becoming more accessible. So we have had a number of workshops looking at AI through the years, and I think the technology is on the cusp of being more accessible to researchers. And so can we invest in some of these resources, make it accessible to the community, because those GPUs are not cheap. Having we don't want just these large, well-funded research institutions to have access to this thing. So no matter where you're coming from, to be able to have like a web-based portal where you can access some of these data and some of the GPU and computing power for these AI models to train, and I think is important, and one of the priorities of NIH to try to democratize it. But we're starting well behind industry in terms of their computing powers and the resources that are available. And so we're thinking across NIH and the other federal institutes like National Science Foundation. Can we partner with them, with DOE and the national laboratories? Can we do something to try to leverage and take advantage of these new technologies and the vast amounts of data that are available and that are required for analyzing using these types of methods. But the data really are now available at multimodal biobank scale. So genome, phenome, exposome data from these large biobanks like NHANES, UK Biobank, the All of Us program, CMS AHRQ, even the SEER program are able to address these questions of interest. And so one really interesting in terms of the EHR data is the National COVID cohort plot, where it kind of showed where if everyone kind of put their minds to it and shared their data, there was a huge amount of data that was available in these clinical and electronic medical records. If people put it in there, made it accessible, and so that was a model that was successful. But I think a lot of partners were very protective of their data and their data systems. So how do we kind of bridge that and allow access for researchers to study these things? And ultimately trying to put the state of the 80 knowledge portal, bring it together with these smart city initiatives like with 5G, satellite sensing, Internet of Things. Can we kind of put this all together and look at real world data, collected from these cities, overlaid together, and then look at these diverse data sources? How can we leverage them to look at the use of long latency like AD? And so, there's a lot of limitations in terms of the current exposome data analyses, in terms of scalability, data variety and complexity. Very slow pointer here. Sparse and missing data. I'm trying to hurry up. So save time.
Fine.
Yeah, I know you're looking at the clock.
We are doing okay.
So some common themes are that the available data are often underutilized in biomedical research. So there's a ton of data that I'm seeing there that no one knows what to do with. Or they just hadn't had the right approach in terms of having someone coming in with a fresh set of eyes with a different perspective. A lot of new methods and algorithms and tools and systems and interdisciplinary teams are needed really to incorporate the complexity of the data that are available. And really, there's a lot of challenges in terms of harmonizing and integrating this data to really build these predictive models at the individual level, and then really try to characterize and mitigate these inequalities both in health and healthcare research. So we have had a number of investments in the exposome recently. And so these are just some RFAs that have recently come up. You can scan the QR codes to read more about them, and work closely with Damali, Martin, and Dallas Anderson, in these efforts, but also with Suzanne Haneska, Alison Yao, and Amelia Carricker, and Emerald Schwinn, and Dave Jett over at NIEHS, and Michelle Beacock at NIEHS, in terms of funding a lot of these opportunities, in looking at the environmental. So the AV Summit is coming up in September, and these are the list of some of the topics of emphasis that we'd be very interested in. And And several of them are relevant to this workshop in terms of digital technologies and blood-based biomarkers, understanding the exposome to inform the development of risk reductive strategies, and also irrigated ecosystems for ADHD research. So I want to leave time for some questions. And so, but if you have any additional questions, feel free to email me and you can scan the QR code and generate an email. So thank you for your time.
Great, amazing job. Let me, on behalf of all of us, especially I go about with others, NIA had been in the front line in terms of funding, especially when it comes to aging and post-AD. One of the better institutes that have tried multiple institutes where you could get funding. So one message which was clear out here to me was that those days of keeping your data to yourself for the institute are over. And that's very important to learn, follow up with the program officer and share. And number two, for somebody like me with gray hair or no hair, learn AI and application of AI, clinical informatics. I'm talking to the three of you in front. And you guys, the younger guys, you will be the one who will be taking the baton. We have done, Dr. Z and others, that we have contributed whatever we could do at more or less R01, those kinds of levels. Those days are over. Including consortiums, be it ADNI and others. So I wanted to thank you on behalf of all of us, the NIA and the you guys, for helping us out. Any questions?
Always think where to submit a grant with population studies and environmental exposure for aging or to NIRS Institute. How would you say which one should be submitted there and which one should be submitted?
We do have better pay lines than NIH. It really depends on what the focus of the research is and where you're trying to explore. But NIA is very interested in not only AD/ADRD outcomes, but precursors to it. And so if you are anywhere along the etiological pathway, I've been really encouraging a lot of my grantees to apply to NIA. We have a number of programs, and if you are looking for a PAR or an RFA that might fit, reach out to a program officer. We have a number of blog posts but that the NIA program officers author expressing their interest in different topic areas that are related to AD/ADRD and aging. And don't be afraid to send them an email and set up a time to talk about, like, I'm exploring this thing. Here's how I would like to frame it. And they can provide a lot of useful advice in terms of how you cater your grant application, how you frame it. It may not be successful the first time around, but because that's up to a scientific review that the program officers don't have anything to say on, but they can give you some pretty useful advice. And so I think for the younger folks who have or just embarking on their careers, your program officer should be your best friend. You should know them and communicate with them, because they can do a lot behind the scenes that you may not be aware of.
Yes, sir.
Yeah, when you were talking about exposures, you mentioned UK Biobank and all of us studies. Can you please elaborate a bit more about all of us? Which kind of exposures they have or they plan to have? Maybe you know something about that.
Yeah, so all of us just recently, so I've been in contact with all of us and Jeff Ginsburg and Lou Berman in terms of helping them set up a new environmental component that they're trying to look at, obtain a residential history of all of their participants. And then from that, I think they're calling it CLAD, Center for data linkages. and to link the data to these large data sets and data repositories like the EJ index, I think is one of the first ones that they're going to try to link it to. And so that should be coming out in the next year or so.
Maybe you have some plans to harmonize collection of environmental data with UK Biobank? No?
We would be in conversations with them as well in terms of trying to provide better calculation longitudinally of their exposures. There's also a number of different studies coming from like the birth cohorts and adolescent studies as they are aging. Some of these studies are like AdHealth is 20, 30 years old that when they were first enrolled, and now they're kind of aging into middle age and beyond. So starting
about 2000, UK Biobank, for example, half a million. So right?
Yeah. So I mean, there's even older studies like ALZPAC or Tasmanian birth studies that have gone back decades, and so some of these ones are well characterized from conception and beyond. Would be of interest if they have these stored bank biospecimens and maybe some neurocognitive measures that can be explored. And so that is of interest. And then some mentioned using AI and other different tools that are now becoming available to kind of look at these large copious amounts of data and how to organize and structure it in such a way that traditional statistical techniques have not been able to explore these different associations. We'd be very interested in that.
Great.